Welcome to Part 8 of this series of slideshows that describes the mammalian stress mechanism that was predicted by Hans Selye. This presentation will explain the capillary gate mechanism that is part of the capillary gate component. The turbulence mechanism will be explained in the following slideshow. This slideshow reviews the enzymatic interactions that generate and disintegrate insoluble fibrin in accord with autonomic balance. Sympathetic activity releases von Willebrand factor to generate insoluble fibrin, and parasympathetic activity releases nitric oxide to disintegrate insoluble fibrin into fibrin split products, or FSP. The diameter of capillaries is barely adequate to allow red cells to travel single file. Sympathetic nervous system activity extrudes von Willebrand factor from binding sites on the inner walls of capillaries. These von Willebrand factor binding sites are located next to binding sites for fibrinogen and fibronectin. Factor VIII in flowing blood binds to von Willebrand factor, which activates the VIII enzyme and generates insoluble fibrin strands on the inner walls of the capillary, shown in blue. This closes the capillary gate by slowing the passage of red cells through the capillary lumen. Parasympathetic nervous activity releases nitric oxide from capillary walls, which binds to calcium, inhibits thrombin activity, and accelerates the degeneration of insoluble fibrin into fibrin split products. This restores tissue perfusion, tissue oxygenation, organ function, and cardiac efficiency. The capillary gate mechanism is efficient and effective because capillary turbulence, flow, and pressure are negligible, and capillary surface area is vastly greater than all other vessels combined. The mechanism does not normally halt capillary flow or reduce perfusion to the point of causing ischemia or infarction, as evidenced by the absence of tissue ischemia and infarction in health and youth. But chronic hyperactivity of the mechanism accelerates the capillary deterioration that is part of the normal aging process. I call this accelerated capillary senility. The premature destruction of capillaries compromises tissue perfusion and oxygenation and predisposes to tissue ischemia, infarction, eclampsia, and organ dysfunction, and particularly congestive heart failure. Capillary hemostasis, which completely halts the passage of red cells through the capillary lumen, normally occurs only when tissue disruption directly exposes blood enzymes to tissue factor in extravascular tissues. Capillaries inexorably deteriorate and disappear as a natural consequence of the aging process, so that tissue perfusion is progressively compromised. Combinations of sedentary lifestyle, morbid obesity, emotional stress, trauma, surgery, and exposure to toxic chemicals and radiation can abnormally accelerate capillary senility. Accelerated capillary senility is the occult cause of type 2 diabetes, senile dementia, renal failure, essential hypertension, congestive heart failure, and eclampsia. Type 2 diabetes and essential hypertension seem totally unrelated, but they are the same disease. Though the severity of individual symptoms and manifestations are unique to individual patients, all are caused by accelerated capillary senility that simultaneously exaggerates capillary flow resistance and undermines glucose uptake by cells. The early stages of the disease are characterized by normal blood pressure at rest, exaggerated blood pressure in response to exercise or mental stress, small amounts of protein in the urine, and an impaired ability to process sugar. As the disease progresses, blood pressure remains abnormally high at rest, blood glucose levels become continuously elevated, and symptoms of progressive organ damage appear. The increased flow resistance exaggerates cardiac work. This does not cause the heart to become bigger and stronger. Instead, it induces fibroblast proliferation and collagen deposition in heart tissues that progressively undermines cardiac function, even though it causes heart walls to grow thicker. Eventually, this results in congestive heart failure. Exercise conditioning is the opposite of accelerated capillary senility. It induces capillary proliferation and muscle cell hypertrophy in the muscles and tissues affected by exercise. For example, running induces capillary proliferation in leg muscles, and weight training induces muscle cell hypertrophy in arms. The capillary proliferation reduces capillary flow resistance and enhances tissue perfusion and glucose uptake by cells. It enables tenfold increases in cardiac output during intense exercise, with little effect on blood pressure and negligible increases in cardiac size, weight, strength, and power. Exercise conditioning is thus beneficial in both diabetes and hypertension. In fact, it may be the most effective and least problematic treatment for these illnesses. Insulin and epinephrine are opposing hormones that extend autonomic effects to peripheral tissues that lack direct autonomic innervation. Sympathetic activity releases epinephrine from the adrenal glands. Epinephrine releases von Willebrand factor from the vascular endothelium, which closes the capillary gate. Epinephrine effects are most prominent in peripheral tissues, where direct sympathetic innervation is lacking, so that epinephrine enhances vital organ perfusion at the expense of peripheral tissues. Brain astrocytes produce TPA that preserves brain perfusion and prevents ischemic brain damage despite epinephrine dosage during cardiopulmonary resuscitation. In contrast, parasympathetic activity releases insulin from the pancreas, and insulin releases nitric oxide from the vascular endothelium, which binds to calcium, inhibits thrombin activity, opens the capillary gate, and enhances tissue perfusion and glucose uptake. The effect is most prominent in peripheral tissues where direct parasympathetic innervation is absent. Insulin is therapeutic because it prevents cell glucose starvation, but sulfonamide treatment is harmful because it aggravates cell glucose starvation. Understanding capillary gate operation and accelerated capillary senility confers an improved understanding of eclampsia. As mentioned in the previous slideshow, pregnancy exaggerates factor VIII activity, which closes the capillary gate and inhibits tissue perfusion. It also introduces the risk of meconium embolus, where large amounts of tissue factor enter the bloodstream and cause systemic factor VII activation. In most cases, accelerated capillary senility remains occult and overlooked in breeding age women, but pre-existing diabetes and hypertension exaggerate the risk of eclampsia during pregnancy. The occult accelerated capillary senility causes glucose intolerance and hypertension early in pregnancy, as the metabolic demands of pregnancy exaggerate perfusion requirements, while the stress of pregnancy closes the capillary gate, exaggerates flow resistance, and inhibits cardiac output, tissue perfusion, and glucose uptake. The onset of labor pain sharply exaggerates sympathetic tone and activity, closes the capillary gate, and causes the severe hypertension and glucose intolerance that characterize eclampsia. In addition, the stress of pregnancy accelerates capillary senility and exaggerates the incidence and severity of hypertension and diabetes in its aftermath. The next slideshow will discuss the turbulence mechanism, which explains why eclampsia is closely associated with DIC. It's time for another break. The next slideshow will explain the turbulence mechanism, which regulates turbulent blood viscosity in arteries and arterioles in accord with autonomic balance and complements the capillary gate mechanism.